Hi, everyone. Welcome to the Foundation briefing on industry AMR surveillance data for action. My name is Rebecca Lee, and I am the Executive Director and leading this AMR initiative. Vivly is a global data sharing nonprofit that is leading this initiative, and we are very happy to have you here today. Few housekeeping items before we start. This meeting is being recorded for internal purposes. A summary of the meeting will be provided afterwards. And please, those of you that are attending will be receiving a summary of this meeting. Please post your questions in the Q&A section. Each of the panels will have a Q&A section, and we certainly hope that you participate. We'll respond to your questions during the Q&A sections. All of you will be muted during the duration of the meeting. We have a very full agenda today. We call your attention to the full bios and agendas that will be attached and have been attached to your invitation and your calendar appointments. The objective of this meeting is really to discuss the urgency of AMR, the importance of industry surveillance data, and industry's experience in this area. We'll be able to hear directly from industry on this topic. And we'll also hear from researchers who are working in the public health arena on the benefits and value of this data. Professor Dame Sally Davies will be giving remarks on this at 9:30 Eastern time, and we will also introduce you to industry surveillance, the AMR platform, which will be launching in 2022. Q&A will be embedded throughout each section, and we really look forward to hearing from you all as participants. I'll be also wrapping up at the end and talking about Vivly, who we are, and how we'll be contributing to this AMR effort as well. I now will invite Dr. Tim Jinks to join me at the virtual podium to give his opening remarks. So Tim, if you can unmute. Oh, thank you. I see you. Tim?
Great. Thank you very much, Rebecca. And hello, everyone. I'm Tim Jinks. I am the head of infectious diseases interventions at Wellcome, and included that is our strategic priority focused on AMR and drug-resistant infections. Probably there's no one in this audience that does not appreciate the importance of the threat that AMR serves to global health and the lives that is costing many people in many places today. But nonetheless, we need to make sure that we keep a focus on this issue as an important one that stays on the radar screens and the agendas of countries and others as we are moving forward and emerging from the peak of the COVID pandemic going forward. A number of things that we've learned in COVID, I think, that are relevant to us here today, but very important that we do remember that AMR is that silent pandemic, that slow-moving pandemic, and one that still requires very urgent actions and actions that continue over a longer period of time. Related to AMR is the issue of understanding what is happening on the ground. And this really gets to the heart of the role of the data sharing that we think is very important here. There's insufficient surveillance to support the world's needs to understand what's happening with respect to drug-resistant infections and the pathogens that cause those. So, as we look at that situation and think about what needs to happen to provide the data and inform decisions, actionable decisions, there are a number of areas where that job is already being done in part, and we can actually mobilize data that's being generated to make it useful today so that we can see real change in the near term and not sit back and wait for some hypothetical new system to come into place at a later date. Alongside that, of course, one of the things we've learned is the importance of sharing data and open data. COVID has shown that it is doable and that sharing data actually achieves real results. We think it's very important that in the realm of AMR, all AMR data should be openly accessible and shared so that we can have a better global public health response to this threat. Today is focused on industry-generated data. Wellcome identified vividly as a platform that can bring together industry-generated data and make it available openly to really address some of the key questions related to AMR. This is a pilot activity that is one that we believe can serve a long-term purpose and be one of the key ingredients to solve the problems related to an information deficit on AMR. So one of the things that we think is very important, we want to invite industry to provide the data, to make it available so it is then accessible and can be used and then ultimately prove useful in broader ways, and in some ways that might even be unimaginable today. But certainly from the expert speakers we'll hear later, exactly how data that's generated for one purpose can be reused meaningfully and become actionable information in other contexts. So industry, please do listen to this and think about how you can best make data that you're generating available for open sharing through this platform. Now, Wellcome looking at this as something for a longer term point of view. And we hope that at the conclusion of this pilot, if all the milestones are met, that we would invite other funders to come in and we would want to match funding to have a long-term, more sustainable position for this platform. So with that, I think I will hand over to the next person who will introduce our first speaker today. But thank you very much for joining us.
Thank you, Tim, for your remarks. And I'm very grateful for Wellcome's generosity and for funding us through the launch of the AMR platform. I'd like to introduce next Mark Mendelson. I'd like to have him come on and start sharing his slides. Dr. Mendelson is not only the chair of our SAB, but he is also the professor of infectious diseases at the University of Cape Town. And I really am delighted to have him give our first talk today, who will be talking about the AMR landscape and importance of AMR surveillance. So I'll turn it over to Dr. Mendelson. Mark.
Rebecca, thanks very much indeed. It's a great honor to be presenting today and to chair the SAB on this really exciting new venture. So thank you to everybody involved. I've been asked to give some opening remarks about the AMR landscape and the importance of surveillance. I have no conflicts of interest that would prevent me from giving these remarks, and none relevant really to this topic. Rather than give you the sort of standard definitions of what AMR is, and I'm speaking to an audience that are very well versed in this, I thought I'd try and reflect on what I feel is some of the critical important issues around AMR and surveillance. But in general, to start off, I think what we're seeing with antimicrobial resistance is similar to what we're seeing with climate change and other disasters, is that AMR, I believe, is an ecological disaster in keeping with climate change, in keeping with the encroachment on populations of animals that are increasing our links to zoonotic diseases, not perhaps this slightly bewildered koala, but COVID, again, has taught us the likelihood of encroaching on environments and environmental destruction. But in AMR, the environment is our own. We are unable to live in symbiosis with microbes, the bacteria, viruses, fungi, and others that live in and on our bodies and outweigh the number of cells that we have as humans. And our symbiotic relationship with these microbes is critical to the functioning of our immune system, digestive systems, and the working of our body. And as can be shown here, there are microbiomes, microbiota in all different areas of our body, and there are increasing associations when we destroy these in relation to diseases. And so I think we are not reaping the rewards of living in symbiosis and preventing disasters of our own ecology. I also believe that although the war rhetoric that has framed AMR in recent times, which has been useful in trying to engage people into action, again, because of this idea of destroying bacteria, is the wrong framing at present. And I hope that we will move far more towards an ecological viewpoint of how to reduce AMR. Now, AMR, in terms of how it impacts on society, we've been focused on deaths in the year 2050 as our main focus, dating back to the O'Neill report, again, to try and garner action. And Tim's comment that this was a slow pandemic doesn't quite fit with how we experience it at the coalface. And this is of interest. To me, AMR is an intensely personal issue to people, and it relates to loss. Now, 20 years before penicillin was even invented, and 40 years before it was first used, this newspaper cutting describes a person who was mowing the lawn in an athletic field, cut his toe, and had to have his foot amputated to control infection. Fast forward now to this year in my hospital, where an untreatable Acinetobacter infection of the knee required amputation of the patient's limb above the knee. Very little difference in the outcome, but the realization is that we have reached a point where we are needing to use extreme measures to control bacterial infections in our patients. So what is happening in the here and now, and is highly relevant. Obviously, this, our knowledge of this was through surveillance, through diagnostic surveillance in this case, and highlights the critical importance of that. The other thing that COVID has taught us is the importance of real-time surveillance. And the whole way surveillance has been thought of now, I think, has changed and is changing with COVID. And again, I come back to this fixation that we've had with the year 2050, and that's difficult to get people engaged in. It leaves them removed from the reality of the here and now. But the surveillance systems like the Hopkins dashboard, and more recently the COVID visualizer shown in this slide, really gives you up-to-date surveillance of the problem, which is what we need. And we need to do that, we need an entire picture, which includes a lot of the data that we're now looking to and the subject of this endeavor. So what constitutes surveillance as well is expanding. We've done metagenomic analyses of cities. We've looked at sewage, particularly in the COVID era, but that sewage analysis is also pertinent to antimicrobial resistance. So the amount of different data we have and the scope of the data is changing and developing, and we need to, going forward, bring that into the fold. And national reporting of AMR data is improving, and GLASS at WHO and partners are really to be congratulated for really improving the amount of data that we have. And although from 2017 to 2021, as shown on these maps, many more countries are reporting data, the actual data remains incomplete. And what we're actually seeing, of course, is only a small fraction of that, because what we're seeing is largely data that is generated through public health systems and to a smaller extent in private systems. So the data remains incomplete. The importance of having a complete set of data and accurate surveillance helps to inform a variety of incredibly important aspects in mitigating antimicrobial resistance. So when we optimize antibiotic use, we require knowledge of the types of resistance patterns, particularly in the community, so that we can steward our antibiotics, optimize our antibiotic choice in particular to its optimal effect. Now, if the amount of data is incomplete and community surveillance is particularly poorly done, most of what we use, our surveillance data that we use to make our guidance for empiric treatment in hospitals comes from hospitalized patients and the cultures that we get from them. The amount of information we have from community surveillance is very limited, and therefore, although we may be right, we may be wrong in our choice because we're not basing it on the full information. Clearly, also understanding the surveillance in the community allows us in each region of the world and even in our own locales to undertake guideline development, again, trying to optimize treatment of patients in terms of stewardship. If you have real-time data and surveillance, outbreak response can be informed, and again, the importance of community data is critical. And then surveillance will show us new resistance mechanisms, as it has in the spread of many really critical resistance mechanisms, both ESBLs and now more recently in the gram-negatives, obviously the spread of carbapenem-resistant mechanisms. It's critical in policy as well, in informing policy and the ability for us to model the potential scenarios in developing policies, both national and international, and in drug discovery, clearly, particularly in relation to new resistance mechanisms that may come to light through surveillance operations, and in developing clinical trials. So having accurate surveillance data and complete surveillance data is absolutely critical. And I think this is where, lastly, industry data is so important, because at the moment we have missing pieces of the jigsaw, and that is hampering our ability to steward and mitigate antimicrobial resistance. So having industry come on board to provide the fuller picture is going to be critical going forward in our response, our global response to the issue of the pandemic of antimicrobial resistance. And with that, I thank you for this opportunity to talk with you today, and we'll stop sharing my screen, hand back over to Rebecca. Thank you.
Thank you so much. I'm going to bring up Patricia Bradford to see if we have any open questions, or if Patricia or Tim Jinks have any questions for Dr. Mendelsohn.
Yeah, Dr. Mendelsohn, thank you so much for that fantastic overview. To all the attendees, I would just ask you, as we go forward, to utilize the Q&A function in Zoom. It's a little bubble. Mine is at the bottom of my screen. You can access it there and type in a question as we go. Dr. Mendelsohn, when you think about tracking the AMR data, looking for new trends, looking for new, either new mechanisms or new outbreaks, what is your current method of how you go about doing that?
Well, we are needing to use what we have. As I said, it's relatively, not the entire picture. And obviously, in our own regions, we would use our own surveillance data. So what informs South Africa, where I work, We have national systems, a national health system, which we upload data to. I think in terms of tracking more broadly the global data, clearly there are broad databases and very useful surveillance data from ECDC and other bodies. There's also new sort of less formal methods of tracking new surveillance data. One that I've been involved with, and Wellcome Trust is also part of, is the new ProMed AMR database and listing, surveillance listing. As you know, ProMed is reports surveillance data for emerging and re-emerging diseases, and now there is ProMed AMR, which is focusing purely on antimicrobial resistance. So I think as we go forward, there's going to be more and more non-traditional surveillance programs which can be brought together, but those would be the main areas that I would use to track the changes in resistance profiles.
Great, thank you. We have a question from one of the attendees. One of the major challenges is getting outpatient data, at least in the US. Do you see ways that we can use data from healthcare settings as a surrogate for what's going on in the community with AMR?
I think this is one of the, as I said, I think in the presentation, one of the real missing links. The problem is predominantly, for example, say urinary tract infection, most of the data comes from patients who are admitted to hospitals and have samples taken in the hospital. Now, those patients will have already often seen providers, had antibiotics, and will be selecting out resistance profiles that then become thought of as being circulating in the community. Now, some of them will be, but of course we're missing the entire, probably much more sensitive bacteria that are just not being picked up in those programs. So anything that increases surveillance of community infections is critical. And I think there needs to be funding put into community surveillance at primary healthcare clinics, and depending obviously on your setting, it's going to differ how that comes to be accessible. But we make far too many assumptions, and far too much of our data is hospital based rather than the community.
Mm-hmm. Yeah, thank you. So knowing what you know about the industry data that's going to be shared in this platform, if you had one wish of what you could get out of that data, what would that be?
Sorry, I mean, again, apologies to sound like a broken record, but I mean, the whole issue surrounds missing data and the assumptions that we have to make based on the limited picture that we have at present. Industry data can provide a far greater amount of data, and bringing in the different areas so that we will understand. And also a number of trials and industry trials are done in areas and countries of the world that don't have strong health systems and strong laboratory systems, and therefore the data from those countries and those settings can be particularly important.
Another question from the attendees. What messaging do you suggest to get the attention of policymakers and national leaders that have not yet focused on the AMR threat?
I think again, it's about understanding the threat of antimicrobial resistance, how it impacts on the health of populations, how it links into basically all avenues of our lives, and not just in health, but the country's financial, economic futures largely relate to an ability to provide healthcare and population safety. And so I think that the issue is, rather than trying to frame it as a futuristic event, I think we need to show people far more of the here and now of the issue. And that does come, of course, through patient stories and sharing experiences. And I think that's critical. We need to build a civil society of patients and people who are intimately affected, rather than just civil society groups that support, higher level policy and government action plans. The real power is in the people that are affected by this. And I think policymakers should hear more from them.
Thank you. One more question, Rebecca, or are we ready with the next?
Here's my suggestion. I know we have a number of other questions, but we do have a Q&A section after Dr. Canton. So maybe we keep those and then we move on to our next speaker.
Okay. Thank you so much, Dr. Mendelsohn.
Thank you for that wonderful talk. So I'll move on to Tim and let Dr. Mendelsohn introduce our next speaker.
Hey, thank you very much. And it's certainly my pleasure to introduce Professor Dame Sally Davis into this. For those of you who may not know Dame Sally, she's supported the UK government's Special Envoy on AMR in 2019. And she's currently serving as the 40th Master of Trinity College at Cambridge University. I think a very notable aspect of that role is that she is the first woman to do that, demonstrating the flexibility of medieval institutions to move into the modern era. Dame Sally, before that, was the Chief Medical Officer for England and Senior Medical Advisor to the UK government from 2011 to 2019. Alongside that, she's been a leading figure in global health, having served as a member of the World Health Organization's Executive Board from 2014 to 16, as the co-convener of the UN's Interagency Coordination Group on Antimicrobial Resistance, which read out a report in 2019. And then in November 2020, she was announced as a member of the new UN Global Leaders Group on AMR, which is a role serving alongside heads of states, ministers, and other figures prominent in the world, the role to advocate for action on AMR. In 2020 New Year's honors, Dame Sally became the second woman and the first outside the royal family to be appointed a Dame Grand Cross of the Order of Bath for services to public health and research, having received her DBE in 2009. So certainly very high honors recognizing the significant contributions she's made to the UK as well as beyond on important public health issues. So Sally, thank you very much for joining us. Over to you.
Thank you very much. And hello, everyone. It's really exciting to be here today to celebrate the launch of Vivil's, do I say Vivilli's new AMR register. It's something I've been looking forward to seeing developed. As ever, enormous thanks both to Tim and the Wellcome Trust for championing innovative action to stem the tide of drug-resistant infections. And I also want to thank Rebecca and Viv Lee, I can't get it right, for pioneering what we think is going to be an exciting new chapter in data use. I'm delighted you're all collaborating together. And so pleased everyone here today is joining the endeavour. After all, I have been campaigning for nearly 10 years for recognition of AMR and advocating also for action. I've learned and experienced, as many of you have, about how evidence, data, research actually drive action. We need data. But we also see a vicious circle whereby we need far more political and policy action to generate more useful and innovative research. I've been saying there's no time to wait. For many, we know it's too late. They've already died. And unless we act now, the alarm bells are going to turn into a death knell for modern medicine. We all know this, but we still don't persuade the world to move. We know the resistance of bacteria to antibiotics is a growing threat to modern medicine and our ability to treat infections. The resulting burden on health systems and services for care and prevention threatens the delivery of UHC. And we know that AMR throws our current modern advances of treatment, particularly for cancer, transplants, TB, malaria, off a precipice of danger. In the UK alone, there was a 9% increase in deaths caused by drug-resistant infections between 2017 and 2018, over 1 year. And there's emerging evidence suggesting that COVID-19 must be exacerbating AMR due to the increased antibiotic consumption. Not that doctors and nurses were wrong to try and treat patients, but around 75% of COVID-19 patients received antibiotics, despite that only 3.5% and 14.3% of patients hospitalized retrospectively for bacterial co-infection and secondary infection really needed them. We may well see a scenario where this pandemic of COVID-19 actually accelerates the slow pandemic of AMR. Our macro level risk assessments identify AMR as a global shared risk. The WHO included it, after all, in its list of threats facing humanities for the 2020s decade, right along pandemics, earlier in 2019. And the World Economic Forum highlights infectious diseases as a top global risk by impact. And watching COVID-19, we know that has to be true. That's why actually AMR is on our UK National Risk Register as a long-term trend of the same magnitude of threat to flooding, poor air quality and widespread public disorder. Actually, I realise now we're going to have to reassess this. It probably needs to be higher, given what we've seen with COVID-19. And AMR speaks to the weakness of our health system's capacity, capability and infrastructure, which in turn impacts output, productivity and resilience. And of course it matters to patients, but it also matters to policymakers, to industry. We've all got a stake in controlling, preventing and treating infections. Already, as we know, some pathogens, such as Neisseria gonorrhea, have evolved strains that can no longer be treated successfully with any licensed antibiotic. For patients with HIV, 90% of whom receive antiretroviral therapy, 80% have resistance to 2 or more of their drugs. These people are 70% more likely to die within 2 months of being admitted to hospital than those without drug resistance. These are sad and worrying stories and data. As countries around the world collaborate to face COVID-19, we've also got to learn lessons and put them into practice so we don't fall victim to more siloed thinking and lack of preparedness again. COVID-19 has shown us the value of working together and also put a big spotlight on what we could be doing better. After all, it's not going to be the last pandemic the world will face, or the last time citizens globally look to scientific innovation to save us. But it can, COVID-19, be a watershed moment where unprecedented collaboration and trust that different sectors have placed in each other can pave a way forward. During COVID-19, the pandemic, we've seen how data has played a central and vital role in informing local and national decision-making and action. Now, to prepare, prevent and protect us from the AMR pandemic, we've got to strengthen the data and our use of it, and arguably our visibility of it. Currently, the global scale of AMR and antimicrobial use is not fully understood, so we're relying on geospatial mapping and proxies to give us an insight. But without a comprehensive picture, we are operating in the dark. And that's when we look to programs like our UK Fleming Fund that work to strengthen surveillance systems across the world in low and middle income countries, investing in their clinical microbiology capacity to carry out their own surveillance, including submitting the data to GLASS. GLASS may need improvement, but it's important that we all collaborate and share data. Surveillance data is vital at the global, national and local levels. For politicians and policymakers, accessible data provides an understanding and an ownership of the challenge. On the ground, I would argue that data empowers healthcare workers with tools so they can drive solutions that work for the context they, in that place, are facing. Sustainable and effective surveillance systems underpin rapid detection and response. And we're seeing the response to COVID-19 that countries and local areas are using data about spread and rate of infection to introduce local measures. we need to respond to AMR in very similar ways. At the global level, comparing data across countries and health systems enables us to maximize resources and lead a coherent response to AMR with our systems, infrastructure, and stewardship initiatives. So this is why we need to generate and use evidence. We need more evidence of the drivers of AMR, for instance, so we can effectively target the drivers with tailored interventions as well. Take the AMR surveillance platform in Zambia that we fund from the Fleming Fund. The platform was designed to ensure burden-free implementation for health workers, no new data silos, long-term sustainability, and it's open source. Such a bottom-up approach enables data-driven decision-making in Zambia and other countries where they're picking it up now. We should not underestimate the value of targeted, timely, evidence-based care in settings which have limited healthcare resources. But we need to do even more, supporting countries to strengthen their laboratory and disease surveillance capacity, so local action is sustainable, impactful, and centered about the people we need treating. Research and policy making on AMR need to be inclusive and reflective of the burdens of AMR on the most vulnerable and the young. Local communities have to be empowered to make decisions for themselves about their own context, and that depends on building infrastructure and a culture that empowers the researchers in those localities too. So that's why I'm very proud of the collaboration between the Fleming Fund and the International Vaccine Institute to create demand for AMR data. Teams on the ground have been digitalizing, collecting and assessing data in Timor-Leste, Papua New Guinea, Laos, Bhutan, Nepal, Bangladesh. Our joint project will identify gaps in data and areas for improvement in the future. This will be useful for those countries themselves and for policymakers in the region and globally. After all, we've all seen during COVID-19 that the likes of the Johns Hopkins dashboard resonate with both policymakers and public. What people see and understand, they can act on. So with this information up our sleeves, we could then set meaningful targets at local, national, and global levels. Evidence targets would enable us to inform policymaking and innovation, so we can restore the balance and ensure access to treatments, whether an antibiotic, a vaccine, or an alternative therapy. Setting targets would then ensure national and global accountability to do what it takes to reach them. Terribly important. Learning from climate change, researchers have a big role to inspire a new generation of activists for action on AMR. This year, our multilateral actors have moved on AMR. We look to data to turn these steps into strides moving forward. The leaders of G7 committed to act now to strengthen our global health security systems, to bolster our preparedness to tackle AMR, giving an unequivocal mandate for action from all sectors. Our G7 finance ministers have uniquely, for the first time, given an unequivocal mandate and commitment on AMR, and they're showing that tackling AMR is integral to current and future health and economic prosperity. They're going to work, well, actually they are working with health ministers to explore how we can ensure that new and novel antimicrobial treatments can be developed and accessible for patients that need them. And that's across the world. They'll be working with industry too to make sure that innovation works for everyone and reaches everyone. Great news. We're really geeing them up and they've got to deliver. But it'll need to be underpinned by data now and in the future on antimicrobial use, antimicrobial resistance levels to guide our innovation to target the most dangerous and priority pathogens and unmet national health needs, because it can be different from country to country and region to region. I'm also delighted G7 are going to be working with the AMR Industry Alliance to accumulate knowledge of AMR in the environment. We know waterways can be reservoirs of transmission, detrimental to the health of humans, animals, and our environment. But we need far more evidence of contamination, mechanisms, causes, and impacts of AMR emerging and spreading in the environment. This will empower us to agree international methods to curtail it. In fact, Sewage surveillance offers an economically affordable and scalable method of global AMR surveillance and can give us insights into the prevalence and diversity of AMR genes between sites and countries, in the hospital and the environment. So it's clear AMR surveillance is an absolute priority globally and multilaterally. Last year, the World Health Organization with the UN Food and Agriculture Organization, the Organization for Animal Health and the UN Environment Programme launched, as you heard, the Global Leaders Group on AMR, comprising heads of state, ministers, scientists, and representatives of private sector and civil society, with, and I'm honoured to be a member, we're trying to catalyse political action on AMR, advocating for our top priority areas, improved surveillance and monitoring of antimicrobial use and resistance, ambitious science and risk-based global and national targets, and transforming our health, food, and environment systems to be safer with interventions to address gaps in the response to AMR. It's a big ask, but that's why I'm so delighted that VIVLI promises to make industry surveillance data more accessible and usable for researchers, national governments, and multilateral organizations. The register will enable data generators, analysts, and above all, the important users to engage in a close loop so decision makers can use all that data almost in real time. I applaud and thank the contributors to the pilot phase, for instance, Pfizer, Merck, Shionogi, Johnson & Johnson, and GSK. This data builds on the great work pioneered by the Open Data Institute and the Wellcome Trust, and by providing open access to industry-generated bacterial pathogen surveillance, data has the potential to serve as a long-term global resource for sharing industry-generated surveillance data. Thank you, all of you. The more coordinated and accessible our data is, the more able policymakers will be to translate the data into meaningful action. Industry, patients, and healthcare workers can all benefit from this, which is why I encourage all industry to contribute to the register. We've got to work together using our capacity to influence and to drive and harness our knowledge and be more than the sum of our parts. Then, if we deliver that, we will have learned our lessons from COVID. If we want to have antibiotics and other antimicrobials for the long run, then this is a long game that we need to play together. And I hope that we can all play our parts to support the VIVLI platform in any way we can. I look forward to seeing the progress as we go forward. Thank you, Tim. Thank you, everyone.
Great, Dame Sally. Thank you ever so much. And thank you for your leadership in this topic. And with the start of today's meeting, setting the context not only of the importance of data sharing for addressing the needs for treating patients and public health, but putting it in that broader context of the political dimensions and dynamics that are going on overall, so that we can hopefully achieve a more joined up and coordinated progress on all fronts of the AMR agenda. Again, thank you for joining us and leading us forward in all that we're doing here. I will move to our next speaker, who's Dr. Raphael Canton. Dr. Canton will be speaking about the AMR landscape and the importance of AMR surveillance. He's currently the head of the clinical microbiology department at the University Hospital Ramon y Cajal, an investigator at the Ramon y Cajal Institute of Health Research, and an associated professor of clinical microbiology at Complutense University of Madrid. He's currently clinical data coordinator of the European Committee for Antimicrobial Susceptibility Testing, otherwise known as UCAS, to those of you close to the space, and a member of the advisory board of the Joint Programming Initiative on Antimicrobial Resistance. He's been the president of the Spanish Society of Infectious Diseases and Clinical Microbiology, ad hoc member of the steering committee of the European Society for Clinical Microbiology and Infectious Diseases, and associated editor of Clinical Microbiology and Infection Journal. He is extensively published author, over 500 articles in medical journals and 55 book chapters, in the field of clinical microbiology and antimicrobial resistance. Dr. Canton, thank you very much for joining. Over to you.
Well, thank you very much, Dr. Jinks, for the presentation, and I'm very glad to be here with all of you in this BIBLI initiative on antimicrobial resistance. So my role here is just to go in details about antimicrobial resistance surveillance. I would like to just to remark my disclosure here. It's mainly related with participation in educational program, and I have to confess that most of them has been related to surveillance and to share data of surveillance and also the analysis of them. And also I have some research participation that is also related, most of it, with surveillance. So this is my outline of my presentation, and I would like just to start what we do understand with surveillance. We have been talking about that, but I think it's good just to remember which is the definition. Probably you will find another definition that is included here, but I just found this in a book. It was published in 1996, and it defines surveillance as an ongoing and systematic collection, analysis, and interpretation of health data essential to the planning, implementation, and evaluation of public health practice. But for me, probably one of the most important concepts in the definition is that I have remarked here. The data are collected to share with those who need to know. And I think this is quite important because these data are used in the case of the public health and also an antimicrobial resistance to control and prevention of human disease, including obviously antimicrobial resistance. So we have different programs on that. It's related to infectious diseases, it's related to antimicrobial resistance, which is the topic that we have today, and also it's related to the antimicrobial use. Obviously, if we have to go in details of antimicrobial resistance surveillance, we will interpret this in light of the antimicrobial use and also on the infectious disease. And also, particularly in the public health area, they like to differentiate in terms of the surveillance and also the monitoring. The monitoring is just to understand, to do an analysis of what is happening with this surveillance data. I think this is related according to the definition that I use from the book that I was highlight and I found from 1996. But I do not understand just to collect the data and not to do a monitoring, because this is important just to take some action related to the data that we are collecting. I start my residence in clinical microbiology at the very beginning of the 20th of the century. And well, I was in the group of Fernando Vaquero. Fernando Vaquero at that time just told me, well, Rafael, why not to collect the data on Staphylococcus pneumoniae, also Haemophilus influenzae, and also Moraxella catarrhalis. That was a respiratory tract pathogen. It was important at that time to understand what's going on antibiotic resistance. So I started collecting this data. That was really a surveillance study that was sponsored at that time by Bichan. This study now moved to another platform, to another company, which is DSK, and it's the SOAR surveillance study. But I understand at that time that surveillance was not only collected data, it was also to use this data to guide antimicrobial use, to do research, to do education. It was quite useful, obviously, because this was the founder of the industry, to use this data to understand if the antibiotics that were introducing has some, let's say, ecological effect on the microorganisms. It means the antimicrobial resistance development, and also just to understand if we can use this data to control antimicrobial resistance. I think this study, the Alexander project, this was the name of this surveillance study, put the pillars of the antimicrobial surveillance study. And we understand that this was the first step that has to be used to stop the development of antimicrobial resistance. Again, we need to know what is happening on antimicrobial resistance. This is surveillance. We need to analyze and we need to take some action. Obviously, this was not the only initiative on that. I here highlight the plan of the global strategy for containment of antimicrobial resistance of the WHO. And in this plan, and the next one, which was in 2015, the Global Action Plan of Antimicrobial Resistance include different objectives. The second objective of this plan, the one from the 2015 from the WHO, is strength and knowledge and evidence-based through surveillance and research. So again, it's highlighted the antimicrobial surveillance in the international plans of the global public health agency. Obviously, these programs are also present in Europe, also present in United States, are also present globally from the WHO. This is the European One Health Action Plan against antimicrobial resistance. And again, here in this plan, which is from 2017, it is highlighted also the surveillance of antimicrobial resistance. It says making the European Union a best practice region, better evidence, better coordination and surveillance, and better control measure to address antimicrobial resistance. Obviously, and that has been said by Mark previously in his talk, it is the GLASS initiative, which is also a program with the WHO. So which type of antimicrobial resistance surveillance we have now, and those that we know that are active at this present. Here you have a list of different programs of public initiative. Obviously, one of them is the EARSnet. There is another one that has been related with another countries, for instance, the NARMS in the United States. The USCAPE is related to a very particular type of microorganisms producing carbapenemesis, which is a problem that is quite important nowadays for the use of antimicrobial agents. We have the CSAR, we have the GLASS, we have in South America an excellent also WHO initiative, which is the RELABLA, just taking also data on antimicrobial resistance. And we have also a plethora on international programs that are funded by the industry. There you have, obviously, the Alexander project is not the 16th program now. This is now the SOAR, as I previously said, but we have also names that probably you are familiar with, which is the Artemis, the Focus, the Global, the Mystic, the Protect. Previously, that's not the 16th now. We have the SOAR, as I mentioned, the TEST, the CIREVA, and the SAPS. And these programs are related to a specific problem. Some of them focus on microorganisms using this data as a sentinel. Another one is using that's covering very specific areas in different places. Some of them share different breakpoints, CLSI and UCAS, and also all of them tested different antimicrobial agents. And also, which is important, and I will give some points of that, is the use of these programs for the industry, for the approval, and also for the post-approval authorization of the antimicrobial agents. This is, for instance, one of the examples, the EARSnet. The EARSnet is in Europe. This is a public funded system for antimicrobial resistance surveillance in Europe. This is based on routine clinical antimicrobial susceptibility data. We send this data to a central laboratory in each country. And at the end, these data are collected by the ECDC in Stockholm. And this is published in a public website just to see how is developed the antimicrobial resistance. It is important to understand that in this public surveillance study of antimicrobial resistance, they use different different microorganisms as an indicator. They are sentinel bacteria to understand the antimicrobial resistant evolution at development. And this is the microorganisms that are studied in the EARSnet. You can see this in this table, different microorganisms, gram-negatives, also gram-positive, and also take some of the antibiotics that are used to understand the development of resistance, third generation cephalosporin, the carbapenems, or the penicillins for the gram-positives, or again, the use of third generation cephalosporin or the glycopeptide, just to understand the development of antimicrobial resistance. And you can go to a public website just to download the data. And in this web page, you can see also the evolution. I just captured some of this resistance. I take the example of the carbapenem resistant in Klebsiella pneumonia, and you can see how this has been increasing just seen which are the colors initially, most of them in green in Europe, and how this color has turned to another colors that are more hotter, just trying to understand that was the development of antimicrobial resistance in this case. Also, we have the CISAR. The CISAR is quite similar to the EARSnet, and also you can find this data in different reports that can be also downloaded for the different web pages of this surveillance study. So which are the challenges of current antimicrobial resistance surveillance? We have understand through this year the increasing complexity of the resistant profile and resistant landscape. We need to increase the number of antimicrobials tested and targeted microorganisms. We have been also learned the rapid evolution of the resistant mechanism and the multi-drug resistance. It's now difficult to infer resistant mechanisms with the phenotypic testing. Most of the surveillance studies are based in the MIC testing, and we need to apply molecular testing, PCR, whole genome sequences. This is something quite important right now for the antimicrobial resistant studies. Also the globalization of resistant mechanisms, but even despite this globalization, we have different local epidemiology. We have also know, because we are using these whole genome sequences, that sometimes we capture cryptic resistant genes that are not expressed, and we have to understand also what it means for the development of resistance. We have different breakpoint systems. Also, we have to understand also through surveillance which are the different, and also it's quite important to understand that doing also this work, the cost at higher than previously using this surveillance activity. And also that this has been highlighted previously, that we need real-time reporting or surveillance data. Just an example, this is the antimicrobial that has been approved by the FDA and also the European Medicine Agency since 2010, the increasing number of these antimicrobial agents. And we need to complement the public surveillance study with also pharmaceutical development surveillance study, just to track which is ongoing on the surveillance of these antimicrobial agents. What to say about the complexity of the antimicrobial resistant landscape? Here is carbapenem resistant microorganism. We have been discussing just to differentiate which is a carbapenem producer from the point of view of a carbapenem resistant mechanism. This is something that we can understand now with the antimicrobial surveillance studies. And also, this is a guideline that has been published by the WHO, just to trying to highlight the importance of using the whole genome sequences in the surveillance study, to track the clones, to track the antimicrobial resistant mechanisms, to track the outbreaks, to study probably new targets for antimicrobial resistance, because we have the full sequences of the microorganisms, and also for the development of vaccine, and also to develop some testing in the laboratory. This is an example that we have done in our lab. This is a study that we performed in Spain and also Portugal, just trying to understand differences in these two countries. And you can see in the part of the right in the diagram, the figure, that here is a different distribution of the MIC to a new antimicrobial agent. This is the tolzol and tazobactam, and how is the different on antimicrobial resistant mechanism, mainly due to the presence of different carbapenemases. The figures are different in Portugal and also are different in Spain. So this is something that we know regarding the antimicrobial surveillance. So what about the private antimicrobial surveillance programs? This is mandatory, at least in Europe, and I think this is also in the United States and probably in other countries, that once the antimicrobials need to be approved, the pharmaceutical industry need to send also data on antimicrobial resistant surveillance. And this is not only have to be done previous to the commercialization, it is also mandatory to do a follow-up, just to trying to understand which is the, let's say, the use of the antimicrobial and the ecological effect that may have the introduction of this antimicrobial in the resistant mechanism of the bacteria. Here you have two examples of this antimicrobial surveillance study, the SMART, which is founded by MSD, and the other one is the ATLAS, which is founded by a Pfizer company. The SMART started in 2002, I think this is a good example. It's a long surveillance study that has been focused in different antimicrobials over the years. Probably it was the interest of the company, ertapenem, ceftolozane-tazobactam, imipenem, relebactam, study different infection, different situation. But at the very beginning, it was only MIC testing, and now it's also performing the whole genome sequences to address also the problems of the presence of this resistant mechanism. And the number of countries that are included in this study is huge, with a number of microorganisms that can be seen regarding this antimicrobial resistance over the year. And this is some figure of the Atlas surveillance study. It is collected by different surveillance studies, like tests that were the INFORM and also the Sentry. And introducing in this web page, you can download also different antimicrobial resistance regarding different antimicrobial. For instance, this is the Klebsiella pneumoniae and also resistant to meropenem. You may have these maps just regarding the presence of antimicrobial resistance. From my point of view, these pharmaceutical industry programs are complementary to the public surveillance programs. They have a wide coverage of geographic areas. They have included a high number of antimicrobial. I put example, obviously, of meropenem, but you can also obtain information of different antimicrobial, and you can use this for potential search of infections, microorganisms, antimicrobial indication, geographic areas, evolution of resistance. So they are richer than the public in terms of obtaining the data to understand the evolution of antimicrobial resistance. They are not only an MIC testing right now, because they are using also the whole genome sequences, and we can track for the resistance and also for the clonality, and they are public available in different web platforms. So I would like to finish with a concluding remark. For us, it's important the knowledge of antimicrobial resistance, but it is also important to control antimicrobial resistance. And I will take the words of Evelina Taconelli in this review, that antimicrobial resistance poses a growing threat to public health and the provision of healthcare. Its surveillance should provide up-to-date and relevant information to monitor the appropriateness of therapy guidelines, antibiotic formulary, antibiotic stewardship programs, public health intervention, infection control policies, and antimicrobial resistance development. And thank you very much for your attention.
Thank you, Dr. Canton. We have a few questions, and reminder to people to type their questions for Dr. Canton into the Q&A bubble. So you mentioned several platforms that are currently publicly available, such as the Atlas platform and what's on the ECDC website. Those have some pre-prescribed analyses that you can pull up, nice maps, etc. So thinking about this current effort, if you had access to the raw data that was behind all that, what kind of analyses would you like to do?
Well, I think you can obtain the data what you want, well, at least for instance, in the SMART database, you can obtain exactly the similar of the Atlas. You can obtain the MIC distribution, for instance. You can use the different breakpoints from CLSI and also UCAS. If there is any difference, you can understand also how this affects to the definition of antimicrobial resistance. You can also download the data regarding the infection sites, and of course you can track for the evolution, because you can do also from different years of the data that are introduced in this database. It is not difficult to do that. It's very easy.
Yeah, thank you. So for either Dr. Canton and Dr. Mendelsohn, maybe each of you can answer, who do you see that the end user would be for this effort of having more industry data publicly available? Who would you see that would benefit most from having that available?
Mark, do you want to answer? Or?
Yes, sure, you can start, Dr.
Well, I think that it's all the, let's say, stakeholders. It's important for the medical point of view, because we can see how it's happened in a country. Probably in the future, it could be also to go in deeper in different areas, in different countries, depending on the hospitals that are introduced. So I think this is good. It is also useful for the industry, because they can compare how is the evolution in different countries. And nowadays, as I said previously, some of these platforms has also data about the resistant mechanism, and why not in the future, because they are doing whole genome sequences to have also the possibility to link this with the evolution of not only the resistant mechanism, but also the high-risk clone. That is another part that is important for us in terms of the evolution of antimicrobial resistance.
Dr. Mendelsohn, would you like to answer that also?
I think Rafael has said it very well. I mean, it is everybody. I mean, each stakeholder will have a slightly different interest in the data and be able to use it. Very important, as Dame Sally has mentioned, for the policymakers to be able to drive national and international policy. So it really does go from the very front line to the grassroots, where we can use it to make better decisions for individual patients, to governments who can make better decisions for in a global sense for their nations and international settings.
Thank you. I'm going to summarize a couple of questions into one, really. Several people have expressed concern about information coming from resource-limited countries. So, we're not talking about starting a new initiative to collect data, but from the data that's already been generated, and we're talking about sharing in this platform, how do you see that this can be of use to people in resource-limited countries?
Well, firstly, there may be data that, that just that in a vacuum almost. Some of the lowest income countries, have very little laboratory capacity, and studies may have been done, and data may be available that starts to give a picture where there is no picture. I mean, I see it as supplementing and again broadening the understanding of the position that a country or a region is in. I mean, Rafael has mentioned different resistance mechanisms, for example. In some countries, there's absolutely no idea which carbapenemase genes may be being transferred, or what the resistance mechanisms are, and that is an issue. I mean, obviously, again, sitting in a low middle income country, one has to understand that surveillance data is critical for trying to push the envelope in terms of access to treatments that you might be able to use for such resistance profiles. I mean, ceftazidime avibactam, for example, which is used widely now in Europe, and is totally and utterly unaffordable in low middle income countries, even upper middle income countries like South Africa, let alone something like cefidoracol, which is completely unrealistic. So, it's great. It'll be great to know what's circulating and to get a better understanding, but it does need to go hand in hand with access discussions around antibiotics or antimicrobials to treat these pathogens. Thanks.
Dr. Canton, anything to add about resources?
No, well, I totally agree, and also it can be used even if we don't have data for a very specific country. We can use the model of the resistance in another countries just to learn about the antimicrobial use. So I think this will be very useful for that.
Do either of you have any thoughts about this partnership that we're launching with industry and Wellcome and Vivli to make this accessible? Do you have any thoughts about this new partnership?
I mean, look, it's a tremendously exciting opportunity, and again, as Dame Sally has said, we've been speaking around this for over a decade. And to see it come into fruition is critical. I mean, we are partners in this industry, civil society, the health services, academia, and funding bodies such as Wellcome Trust. So to start accessing this data, again, gives us a greater picture, a greater understanding of the reality and can only be of benefit. It's a wonderful opportunity from my point of view.
And I think also, Patricia, it's just to remark, is a way to have also this data together. Because, you know, I mentioned the Alexander project. In the Alexander project, it was the production of thousands of data of pneumococci and Haemophilus influenzae and moraxella. And nowadays, it's difficult to find this data. They are in some publication, but you know, in the publication, it's a summary of what has been done. So I think this is also an opportunity to have all the data that has been surveillance, and also for the future analysis that we may want to do. Probably not at the present, because we can focus in a very specific issues or problems, but in the future, we have all this data together to do further studies. And now, and this is something we have to mention, it has been mentioned previously by Professor Sally, it is related to the One Health initiative on the antimicrobial resistance. So we can compare also the human data with the animal data on antimicrobial resistance.
Great, thank you so much. Rebecca, I'll turn it back over to you now.
Thank you so much, Dr. Canton and Dr. Mendelsohn. Really wonderful morning, and thank you, or afternoon, wherever you are. So what we'll do now is go into a 10-minute break. And so for those of you who need a break, certainly take it. What we'll see is just a very short slide reel. So I hope that you'll stay at your desks for at least about 2 minutes if you have time. And what you'll see here during the slide reel is a few foundations and institutes that are deeply invested in this area, as you'll see through the slides. And I know some of you will be checking your emails during this time, but you'll see as we roll through the slides, and you know, some of their work in AMR. And I hope that you do have a moment to look through the slides, and you'll also see their work as they've volunteered some of the slides that you'll be looking through. So you'll see the foundations and institutions that are deeply invested in this area, as well as our developer who will be giving in-kind investment in this work, who is Insight. So thank you so much. We'll be starting back at 10:20 with our next sessions that will be looking at researchers and public health officials that will be, so please put your Q&A in the chat, and we're starting up with that, and then also be hearing from industry who will in the session after that. So thank you so much for your attention and interaction this morning.
Hi, Rebecca, can you hear me?
Yes, hi. Hi, Nick. I can. Do you think you'll be okay for this session?
I really don't know. It has been, it's kind of flipped in and out of connectivity. Much of the last 10 minutes was impossible, but I will do my best. I am here and I am online.
Okay. So I have Gemma on standby. So I think, Gemma, are you okay to step in if necessary?
Well, I have a slight issue with my connection in that I've been kicked out a couple of times, but you'd have to send me over the questions, Nick, that you were planning on asking as well. I mean, I'm not totally comfortable doing it like this, but if there's no alternative, I guess that's what we'll have to do.
As I said, Gemma, I'll do my best, and my connection seems to be better now. So I think we are live at the moment. So
we are.
Thank you for that comment.
Yeah. Hi, everyone. We are ready to start our next panel. So I'm introducing Nick Feasy, Dr. Nick Feasy, and I will introduce Gemma Merritt, who will be introducing our next panel. So Gemma, if you could come on and introduce our next panel, that would be wonderful. Thank you.
Thanks, Rebecca. Good morning, good afternoon, everyone. I'm Gemma Buckland-Merritt, and I'm the research lead for drug-resistant infections at Wellcome. I'd like to thank all of our previous speakers for providing the context and scene setting for today's discussions. And I'm honoured to introduce this next session, which brings together a fantastic panel exploring the use of industry AMR surveillance data from a research and end user perspective. So this session will explore the value and utility of this data and what we can achieve through sharing this type of data with the ultimate goal of benefiting patients. Chairing this next session is Professor Nick Feasy. Nick is a clinical academic at the Liverpool School of Tropical Medicine, and he's a consultant in medical microbiology and clinical infectious disease at the Malawi Liverpool Wellcome Trust Clinical Research Programme. Nick is also the chair of CEDRIC, and CEDRIC is the Surveillance and Epidemiology of Drug-Resistant Infections Consortium. Cedric is a think tank that's funded by Wellcome that brings together disease experts to identify evidence gaps, describe solutions, and advocate for research and policy change with respect to surveillance and epidemiology. And Cedric played a really essential role in Wellcome's early work, exploring how industry AMR surveillance data could play a role in improving our understanding of AMR and be used to inform decision-making and action on AMR. So I'm really delighted Nick is able to join us today and chair what promises to be a really interesting discussion. So without further ado, I'll hand back over to Nick to get the panel started. Thank you.
Thanks very much, Gemma, for that introduction. I will do my best to moderate this session. I must confess I've been having some problems from here in Malawi. I will hand over very rapidly to our excellent panel, Gwen Knight, Nan Shetty, Catherine Moore, and Evelyn Wesangula, to take time to introduce themselves. If we could start with Gwen.
Hello, thanks, Nick. I hope you can stay online for the whole session. My name is Gwen Knight, and I'm an associate professor at the London School of Hygiene and Tropical Medicine. I'm also deputy director of the AMR Centre at the London School. And my research uses mathematical modelling to answer questions about AMR dynamics, looking at both how mobile genetic elements spread and also trying to estimate burden, drug resistance burden globally.
Thank you. Evelyn, over to you.
Okay, good morning, good afternoon, and good evening. My name is Evelyn Wesangula. I work with the Ministry of Health in Kenya. I head the Patient and Health Worker Safety Division here. I'm a pharmacist by training, and I also head the National AMR program. So responsible for the development of policy and the subsequent implementation. And I'm glad to be part of this panel this evening for us here in Nairobi. Thank you.
Thank you. Next, Catherine, over to you.
Thanks, Nick, and thanks to the organisers for inviting me today. So I'm a microbiologist. I've been working in global health for 20 years-ish. I'm a trained biomedical scientist, so I've worked both in the diagnostic and the research side of microbiology. I was previously based out in Southeast Asia, in Laos and Cambodia for 6 years, building the laboratory capacity there. And I fully understand all of the difficulties, or many of the difficulties, of working in lower and middle income countries on microbiology data. But now I have a global presence, but I remain passionate about working with lower and middle income countries, ensuring that local staff can run their own diagnostic and research tests at really high quality. I'm based in Oxford, leading a team working on the GRAM project, and I'll describe the GRAM project later. Thank you.
Thanks, Catherine. And last but not least, Nandini.
Hello, everyone. I'm Nan Shetty. I'm a clinical microbiologist. I qualified and worked for over 15 years in India. I moved to the UK and joined Public Health England. I undertook my clinical training at University College London Hospitals. I am also the co-director of the WHO Collaborating Centre for Reference and Research in AMR and the clinical and scientific advisor to the Fleming Fund. I am intimately associated with the issues and the problems of AMR data gathering, use, sharing, and obstacles thereof in low and middle income countries, small, medium, and large. And I'm passionate about a more open sharing attitude to what data there is available, however little, however niche. And I'm delighted to be here today. Over.
Thank you. Thank you very much. Thanks for those great introductions. And having heard a little bit about you, we can see that we have an excellent diversity of skills and experiences on this panel. I wonder if I could ask you to delve a little bit more into the work you're doing at the moment and reflect on how that it informs our understanding of antimicrobial resistance surveillance. Again, could we start with Gwen?
Hi, thank you. So as a mathematical modeler, I guess without data and without AMR surveillance, I'm really working blind, and there's only so far I could model anything, I could model anywhere. There's definitely the phrase that rubbish in, rubbish out, right? And so my modeling really relies on having good data and a good understanding of what that data is really showing us. The really important thing is to be able to understand patterns and see patterns, and then to believe those patterns, and they're not something that's wrong in the way that the data is being collected, or that not some false something that's hiding something. It's a real pattern that then I need to use mechanistic modeling to try and understand that pattern and the trends going forward. So I'll just give two examples of how AMR surveillance has been really key for answering some of the questions that I've been interested in. So the first one is talking about the global burden of multi-drug resistant tuberculosis. So it's obviously one of the major pathogens when we think about the burden of AMR globally. And the WHO does have a long history of TB global surveillance that I think possibly we can learn from more broadly across the AMR platforms. And using their past data on drug resistance surveillance at the country level, both surveys and surveillance, so individual point prevalence surveys, we were able to fit trend data to try and estimate the annual risk of infection with a drug resistant TB pathogen, so multi-drug resistant TB being resistant to the two key first line drugs, isoniazid and rifampicin. And we're able to use that data to fit trends lines for this annual risk of infection, and then to use those in a cohort model to estimate how many individuals would currently be latently infected with multi-drug resistant mycobacterium tuberculosis. And this is the kind of perfect question for modeling, because it's not something that we can get from clinical samples. We can't find out what bacteria is causing the latent infection. We need to get at it from some other way. And so, but in the absence of this surveillance data, which went back a good 10, 15, 20 years, without that data, we would be completely flying blind, and there would be no way to get these estimates. The second example is some work that directly used the data underlying the initiative that we're talking about today. So that was the Atlas data. It's already been mentioned. The team that I led at the London School of Hygiene and Tropical Medicine, we use this data to generate syndrome level resistance estimates. So instead of talking about the proportion of E. coli isolates that are resistant to a certain bacteria at a certain national level, we brought together, we came up with an index to combine the etiology of a syndrome with the prevalence of resistance within each of those bacteria to say, how likely is it that a bloodstream infection or another type of syndromic infection would be resistant to a certain antibiotic. And that's important because obviously globally, the way that most antibiotics are used is empirically, so without knowing what the underlying infection isolate is. And so with this index, what you can use that going forward is to better design empiric prescribing guidelines. And so with the work that we were able to do, we were able to design this online app where you can go in and you can explore the level of the data and the level of resistance that we found, and therefore what we might recommend based on that. However, very much limited in the coverage that we could find in the data, and obviously our understanding of the collection of the data. And that was one of the things that I hope that we can talk about in this session here, because we did find some very high levels of resistance in certain settings that we weren't quite sure how that matched up, and be really good to explore how we can bring together comparing different types of data to try and get a better level of trust and confidence in the level of resistance in a certain setting. So moving forward, I think AMR surveillance, as I said, is key to any mathematical modeling that we do about AMR to understand both evolutionary trends, to compare and understand interventions. So I think one of the best things to be able to do would be to be able to say this country has high prevalence of resistance and this has low. Why? What's going on there? What are the interventions that are working, and what can we use to move forward? And obviously to quantify, as Dame Sally mentioned today, what the drivers are of AMR and where they're coming from. And without that data, to compare settings and also to look longitudinally, we can't answer those questions.
Thanks very much, Gwen. Your phrase "rubbish in, rubbish out" I think is a natural follow-on to Katrin, who's been leading the GRAM project and will have had experiences of the good and the bad. So I wonder if you could reflect on that, Katrin.
I'm not sure how much I can reflect on that. I can say that there's heterogeneous data throughout the world over time as well, over time and space. So you've touched on the GRAM project. So the GRAM project is the global research on antimicrobial resistance, and our funders are the Department of Health and Social Care, Wellcome, and the Bill and Melinda Gates Foundation. It's a partnership between the University of Oxford and the Institute of Health Metrics and Evaluation, based in Seattle, who've been running the Global Burden of Disease study for a number of years now. And our whole program is to estimate the global burden of AMR, really to understand the burden in more depth than was possible in 2016 with Jim O'Neill's study, to really work collaboratively with industry, with researchers, with health institutes to bring that data together and then understand that burden of AMR. And our work to date covers 204 countries and territories. We're currently in the process of releasing our first seminal paper. It's just gone into the Lancet, so I'm not able to give you any sneak previews yet. But we do have a total of 23 bacterial pathogens and 88 pathogen drug combinations in that paper. And we're estimating the burden in 2019. We've analysed data within that work covering 12 infectious syndromes globally. And we're looking at both mortality and morbidity, so YLLs and DALYs as per the GBD system. Within our study, we've actually used the two different counterfactual measures that are possible to use AMR for AMR. So we've compared resistant infections to drug-sensitive infections. And we've also compared resistant infections to no infection, which some studies have used one and some have used the other, but we've actually used both to say the actual burden will be somewhere in between those two figures. As I said, that's currently under review. And in Oxford, we've really been focusing on analysing the prevalence of resistance. So this is all human data, and we're looking at the prevalence of resistance from 1990 onwards. And what we see through our data gathering efforts and working with collaborators is that the data really only starts to be usable from 2000 onwards. Even if you have a really good research institute who's collecting good microbiology data, it only goes back about 20 years, which actually isn't too bad. So, you know, for the prevalence of resistance models, we're looking at microbiology data alone, microbiology in time and space. But for estimating the global burden, we're really looking for clinical information, microbiology information, and mortality data, which is really quite difficult to get hold of. And I would say that some of the pharmaceutical and industry data that we've been working with has been invaluable in this area, because that data is available in some places through those collaborations. So I think that's really the basis for the GRAM project. What I wanted to move on to was another project where the collaborations that we've forged in the GRAM project has actually been useful to use the data for new projects. We're just starting up the ADILA project, which is antimicrobial resistance prescribing and consumption data to inform country antibiotic guidance and local action. So that really takes it from the global down to local. And what can we do locally with the data that's been shared? And this is a collaboration between Oxford and Mike Sharland at St George's in London. And we're aiming to develop tools that are integrating antimicrobial use and consumption for implementation locally, particularly in national and health facilities in lower and middle income countries. And this is funded by the Wellcome Trust. What we want to do is use community antimicrobial consumption, together with estimates of clinical infections locally, to inform targets for appropriate antimicrobial consumption. And I would stop there and say, Mark is absolutely right on community data. There is so little community data that I'm passionate about actually collecting that data and understanding that data, but there's very little there. So that's one of our ambitious goals over the next few years, as you know, Nick. But we're also collecting hospital data for the ADILA project to integrate individual antimicrobial use and antimicrobial resistance data together with a clinical diagnosis to inform local targets of appropriate antimicrobial use and empiric prescribing guidelines. So it was similar to your work, Gwen, that we're taking that data locally to really understand the infections that people have, the resistance, and what they should be treated with. And then we're assessing the clinical impact of the antimicrobial prescribing targets at a local population level, and integrating those tools and implementing this work, which I think is really key here, actually implementing the work, because over the last few years, we've seen a lot of data sharing, but actually implementation has been quite sparse. So we're implementing the work in a number of lower middle income countries to inform and evaluate policies in those countries. So really, we want to inform national antibiotic prescribing targets based on the burden of clinical infections locally. And I think I'll stop there, Nick. I could carry on for a long time, but all of this data sharing and collaboration that we have within the GRAND project really starts to open doors and build a lot more questions and a lot of trust in what we're doing. Thanks, Nick.
Thank you, Catherine. So we've heard from Catherine about both the strengths and the challenges the GRAND project faced, and we look forward to seeing that paper in the Lancet, which will be out soon, I'm sure. Nan, what's the Fleming Fund doing in this space, and how is it going to improve GRAM2, as it were?
So yes, so I come at this from a completely different angle. And that is, how do we build the capacity and capability of countries to generate their own data? Now, we know that data, or AMR data, is born in a laboratory. And without a robust, quality-assured laboratory process, you will not get AMR data. So the Fleming has started its focus in countries, rightly or wrongly, in building the capacity and capability of laboratories and focusing on quality management systems, on standardization and harmonization of processes, so that the data that comes out of there is robust and is used and is not part of the rubbish in, rubbish out that Gwen talked about. It's useful. And one of the first things that we've realized in Fleming is that to reach that golden point of robust, quality assured, standardized, harmonized data takes many, many years. And the reasons for that are plentiful. It could be that there isn't any local absorptive capacity to train individuals to perform in these laboratories, even if you threw money at them and kitted them out with all the latest equipment. It may be that clinicians don't trust the laboratory to use them. They just haven't been in that mindset to use the laboratory, or they don't trust the laboratory, or the laboratory just does not function the way they want it to function, 24/7, 365 days of the year, with availability of consumables, with availability of clinical interpretation, and that vital link between a laboratory clinician and a ward-based clinician. And of course, we've also heard about the lack of community data. So I want to say that in many of the countries, including in my own alma mater, there is currently very little or no quality assured, robust surveillance data for AMR. However, in many of these countries, there are little islands that are functioning because they are focused on a project. So there will be academia that is doing excellent work, equivalent in quality to any high-income laboratory, because they are funded to produce those outputs. Or there's pharma, who has got permission to go into a big teaching hospital, go to their laboratory and harvest maybe urine samples or sputum samples, or even the organism that's grown at its very basic genus level from a laboratory. And then these are then taken by pharma to their own laboratory, and they are processed, and there's identification that is highly reliable, and it's tested against a plethora of antimicrobial agents, including the experimental antimicrobial agents. So there is this data, and in some countries, this is the only data available. So I am very excited today to be on this panel to encourage pharma and academia to share their data. And what it brings me to my next important point is, are we sure? I mean, some people are sure, but is the global community sure who owns that data? Is the global community sure that, as Fleming promotes, the country owns that data? And so if the country owns that data, is it available freely to at least the country, the country professionals or policymakers for two important areas: to inform policy decisions for sustainability and for just to make them aware of the economic impact of that data and how to use it to make policy decisions, and also to use it by clinicians to make treatment decisions or patient-based decisions. So are we clear? Is the global community clear? And how then will we overcome the reluctance to share that data? Reluctance from the academician who is the principal investigator of the grant, or reluctance of the medical director of the hospital who is invested in the pharmaceutical company working in his laboratory, his or her laboratory. How do we overcome that reluctance? And lastly, I just want to touch on the lack of community data that we've all talked about. Now, I was the chair of a group that was led by WHO Africa to look at guidelines for key laboratory processes linked to universal health coverage. So if universal health coverage is a document, what is the laboratory appendix to that document? What basic laboratory processes should be covered in universal health coverage? And we know that universal health coverage means there is access to health coverage by all peoples, however remotely they are based, however economically they are impoverished or not. And linked to that is what laboratory facilities, what are the basic laboratory facilities that should be covered in universal health coverage? Is it a urine sample or a blood culture? So is there a facility where every single person, if they needed a blood culture or a CSF culture or a urine culture, can either go to a mobile laboratory or could deliver a sample to their primary healthcare center, which would then go to the district hospital and be processed, and they would get access to universal health coverage from a laboratory perspective. And that is the only way I think we will get good laboratory data. Now, in the UK, we are very lucky because GPs send their samples to us, hospital laboratories.
Nan, can I ask you to wind up this point so we can give Evelyn adequate time to give us a view from Kenya and also get
that's me done.
Talking.
Thank you.
Thank you. Thank you. So we are starting to feel a little bit like the blind people and the elephant, in which all three speakers so far have given us reflections on different sciences and different approaches to understanding this problem. Evelyn, could you bring some of these threads together and give us a view on how these differing approaches are coalescing and working together in the Kenyan context?
Okay, thank you very much, and great insights from Gwen, Catherine, and Nan on the place of data. And as I listened to each of you, I reflected on the processes. I have worked across all levels, right from the facility and now at the policy level. So trying to bring all these pieces together to make sense at that level. And I want to begin by reflecting 4 years back when countries were expected to have at least developed a national action plan on antimicrobial resistance. And prior to that, the big question around, and everyone was talking about, was the presence or the availability of good quality data to guide evidence-based policies and treatment guidelines, development or implementation. And when I think about what you have all said, and I reflect on our journey trying to establish and build the capacity of a surveillance system, what we thought 4 years ago is different from what we are seeing now. Because I think at the beginning of the process, we didn't quite understand the extent in terms of investment into a surveillance system to grow it from scratch or even try to strengthen it to a level that it's going to generate good quality data at a country level that can inform treatment options, that can inform good policies, that can tell us whether or not our interventions are working. So one of the things that I see is that we still are trying to answer the big question to keep this discussion at a high level. How big is the burden at country level? And for as long as we cannot answer that question, then the place of investment by governments to sustain all these actions that Nan talked about, you have a project here. For example, the Fleming Fund has come in and it draws to a close after a certain period. What happens next? If you're not able to generate that data and have it at the government level where you're making policies and you're able to adequately define what your burden is like, or at least be able to describe that to those that are responsible for resource allocation, then it becomes a cycle that will continue to be running around because countries need to invest and they cannot invest in the absence of data that is locally generated to guide their decisions. So those are some of my initial reflections on that. And that brings me to the discussion today, which I think is really timely and exciting. And I think for many countries now, we realize that we have to rely on multiple sources of data. Our national surveillance systems might not be robust enough to give us the kind of data in the quantities and maybe the quality that we require after a very short period of being early implementers of the surveillance system. So what that means is we have the potential of tapping into existing data generating systems. And like industry data, we know industry has been collecting data over a long period of time. And like Nan said, who owns the data? Is it fed back to the countries that are generating this data from the beginning? So I see an opportunity because this data is available. And when I listened to, I think, Ronald's presentation, and I looked at the private international programs or projects that are generating data across the world, I think that's an enormous amount of data. So how available is this data? Because we know it's high quality data that has been collected. How available is it at a country level? So we think this data should be shared. And if it's being shared, my second question is on access to the governments and access to the people from whom this data has been generated. Is it coming with a cost? Because I believe it's going to be open access or open data, then countries should be able to make decisions. Remember, as we wait for the publications, as we wait for reports, decisions are being made on either appropriate or inappropriate use of data. So what's the possibility for real-time access to this data by countries to guide, one, their treatment guidelines? For example, I know some countries take a very long time before reviewing their treatment guidelines. And one of the limiting factors is the availability of locally generated data. So is this data going to be easily accessible? At what cost, if there's any? And then finally, what are the modalities of access? How does industry engage the governments that they are working with so that there's ownership from the beginning and there's an understanding that this data is critical, not just for the industry, but for the country as well to make meaningful decisions and also act on the data at the end of the day. And finally, I think I also want to bring in the point of aligning the ongoing global projects being led by pharma to either the existing surveillance systems that are being developed in country or established or being strengthened at any point within the countries, because you'll find the same projects running in the same facilities that are collecting data for the national surveillance system. So I see a need for alignment of this data, which is very valuable supplemental data, especially for low and middle income countries that don't have a lot of resources to adequately invest in their surveillance system, which definitely is a costly venture, like we have realized. And I think when this happens, countries will be able to generate broad pictures of where they are at in terms of burden. And this in turn is going to guide investments by those same countries to sustain the actions that each of us are trying to put in place. So I think from my perspective, that's where I see it's a big opportunity for us to be able to develop how big the problem is, and also a big opportunity for us to begin to see how we can be able to move beyond projects, sustaining our investments, and at the same time leveraging this valuable supplemental data that is being provided by industry. And I think also it provides a point of engagement. One of the things we also learned recently at a country level is that there was a big disconnect between the policy implementation process and what industry is doing. And all of us are trying to pull in the same direction. So it also provides a platform for engagement, for better results and better income. And hopefully when this happens, then our goals will be realized at the end of the day. So I think this is a great opportunity, looking at access, looking at availability. All this is possible if we are all able to agree on the modalities and open it up for countries to be able to define as they move into the next level of developing their action plans. I think we have a better opportunity when we have access to this data. Over to you, Nick. Thank you.
Thank you very much for that wonderful insight, Evelyn. You've really nicely introduced some of the opportunities that the Vivli initiative presents, and I think Rebecca is going to be giving a talk on that to wind up the whole session, and I hope some of the questions that you've posed will be answered in that later. After those great points made by all four of you, we are drawing to a close in this session. I think you've naturally started to address what opportunities to close gaps in AMR surveillance that the Vivli initiative presents. So in the last couple of minutes, I'd just like to throw open a question about what challenges do you envisage in using the Vivli data and applying them to global burden of AMR estimates. And Gwen, can you start that discussion off as you've got experience using these data?
Thanks. Yeah, I'm just very quick so we all have a chance to say something. I just noted a few things down. One of the main issues that we had was when we used the Atlas data, we were trying to really get down to the sample collection protocol. So was it convenience sampling? Was it full denominator prevalence snapshots of data at a certain time point? Was it from a representative sample of hospitals? Probably not community, definitely hospital secondary data. Where are these samples coming from? And then one of the things that we did first of all was to see what level of resistance was coming out at a national level in different types of syndromes and comparing that to the GLASS data and the ECDC data, which we know is somewhat curated and has been available for a longer period of time. And we really found that some of the resistance levels were a bit higher in some of in the Atlas data. And so just understanding why that is, correlating that against other data samples to understand it and move forward. And I think a little bit like Evelyn was saying, in line with who owns the data, how is that data overlapping? So are the same samples being sent to the national surveillance, to GLASS, to the local hospitals? What's the overlap there? And can we do better at this denominator, knowing what's happening in non-infection colonizing samples in the hospital and the community? I'll stop there, maybe pass to Katrin if that's where you're going.
Thanks, Gwen.
Katrin, we have 1 minute, Katrin, to finish off this section of the conference.
Well, Gwen's just said the two that I had on the top of my list, but I had some others. I was thinking, you know, what metadata is there? There isn't much, it's just resistance data that you get. So you don't get the clinical information, you don't get genomic information, you don't get that kind of thing. What about the quality of the data? It's probably pretty good quality because it's sent to the country to be checked. But, you know, it would just be nice to know what the quality of that data is. And then there'd be a mixture of formats in the different spreadsheets, and trying to bring all of that together makes it quite difficult. You know, at my end, trying to work out what the different things mean and are they the same and that kind of thing. So it's a little bit less than a minute. Maybe I can pass over to Nan for 10 seconds or so.
Last comment from Nan, as we're just starting to run over time, and I see Rebecca has turned her video on, which means I think our time is up. Nan, you're currently muted, so I think that indicates you're happy. So thank you for a fantastic session.
Oh yes, I can unmute. I'm so sorry. I have only one thing to say, and that is the data is we don't know whether it's aggregated or disaggregated, but for it to be useful, is there somebody who can analyze it, present it in a report that is digestible either by policymakers or by clinicians? That's me.
Thank you. As we're slightly over time now, I won't go back to Evelyn again. I will instead say thank you to all of our speakers on what has been a really excellent session, and hand the chair back to Rebecca.
Thank you so much, Nick, and for the rest of the panel. Really wonderful and enlightening panel. I learned so much from all of you. I'm going to hand it over to Nina Hill, Dr. Nina Hill, for she's a key member of our AMR Register team, and I'm really delighted to introduce the industry experience in surveillance and look forward to hearing from all of us at the next panel. So I'll just hand it over to Nina and look forward to hearing from all of us at the next panel. Thank you, Nina. Nina, you're still muted.
Okay, thank you, Rebecca, and
Sure.
Thank you, Nick, for such a terrific moderation of the research panel. Good morning. I'm delighted to moderate this panel of industry thought leaders in AMR and data sharing, whose bios you can find in your calendar appointments. The company representatives on this panel have been generating local antibiotic susceptibility data for a long time. They monitor pathogens and changes in resistance patterns through centralized testing using internationally accepted reference antibiotic susceptibility methods. And in 2016, AMR Industry Alliance members committed to continuing to share their surveillance data with public health bodies and healthcare professionals, and to work with them to improve understanding of resistance trends and inform appropriate antibiotic and vaccine use. So all companies on our panel do provide access to their data in some manner through publications, through the ODI pilot platform that preceded our venture, or on their own websites. So to help us work toward building what we hope will be a unifying platform for industry surveillance data, I'll be posing questions to the panel members, and then we'll conclude with a 10-minute Q&A. I'm going to start with a question to Carla Childers from Johnson & Johnson. So Carla, I know you've been involved with the Vivli clinical trial data sharing platform for a long time. So how do you see the Vivli registry driving discoverability of AMR surveillance data?
Thanks, Nita, and thank you so much for including me on this panel of AMR experts. And I'm a bit of an outlier in that I am not necessarily an expert on AMR. My focus is bioethics and policy, but I have spent about a decade working on clinical trial data sharing, as you mentioned, for Johnson & Johnson. And I'm responsible for our process through the Yale Open Data Access Project. So I just want to say, from a threshold perspective, I know surveillance data are different from the clinical trial data, but I do think there are important lessons that we can learn from that past decade of industry sharing. Hopefully most folks in the audience are aware of the efforts back in 2013 and 2014 to create broader independent access for researchers to industry clinical trial data. My own company established a collaboration, as I mentioned, with the YODA project to be the independent reviewer, and it's been very fruitful. We've seen over 250 research proposals. We've had over 60 independent publications by researchers outside our company. We're also a member of Vivli, importantly, and this is where I think it gets to your question, Nina, of we really see it as an important opportunity to cross-list our clinical trials on the Vivli platform while still using our YODA project review process. So we increase visibility of the availability of clinical trial data. But the power of Vivli for us has been the ability to facilitate requests from a range of sponsors and to facilitate access to these data sets when you have multiple different parties that are sponsoring trials. And so we see a lot of power in that aspect. As one might imagine, there's quite a bit of variability required by the clinical trial sponsors, but it's also been a real benefit. So you've got an organization like a J&J who's had a very robust process in place for a long time and have principles and requirements. And yet Vivli also serves the needs of smaller companies, academics, institutions that may need a little bit of a heavier touch and support. And so I think from my experience for the AMR registry, it'll be important to think about where we can leverage those best practices, the visibility from a history of data sharing by industry, and where we can be more creative as we think about access to the surveillance data. And to that end, we've always driven data sharing from a principled perspective. So protecting the privacy of individuals, honoring the terms under which data were collected, respecting, and I think I heard a lot about this, Evelyn was talking about this, respecting the role of governments, regulators, health authorities in making decisions about guidance and practice and use and benefit risk. But then also importantly, really appreciating the importance of preserving the innovative R&D ecosystem and ensuring that incentives remain to develop innovative products, which I think is really an important piece to tease out for AMR. And again, as I said, I think these data don't directly parallel clinical trial data, but I think the principles are still useful. Cross-listing, placing these data on a common visible platform that can enable researchers to find them. I thought Dr. Kenton highlighted this nicely and really talking about the potential benefit of having all the data, or at least awareness of all the data sets in one place. So it's a much more egalitarian awareness of what's possible for the entire research community. So I will wrap up my section of this answer to the question just kind of with a little bit of a call to challenge ourselves to understand where these data may be different and justifiable differences to treat them differently, and where we can also be flexible in how we think about how we've been doing data sharing. And I do think that Vivli can play an important role in driving that alignment and facilitating those discussions.
Thank you, Carla. Such a robust answer. And we are going to rely on you and on Rebecca to help us with lessons learned as we move forward with this registry. Next, I'll turn to Chris Longshaw from Shionogi. So Chris, industry has been cited for its high standards of data collection and analysis. So please let us know what Shionogi's drivers are for your willingness to share data, and how do you ensure data's reliability?
Thanks, Nina, and thanks again to inviting me as well to comment on this panel. I think, you know, reliability of data and data sharing is very, very important to Shionogi. You know, our logo, if you can see on the pillows behind me and my background, are actually, they represent what we in traditional Japanese medicine is called the fundo, which is like a a traditional weight that was used for weighing out medicines back 100 years ago or so. And that kind of, to us, symbolizes accuracy and reliability and trustworthiness. And we think that's very important in terms of our surveillance data as well. I think in terms of how we achieve that, you know, we make sure that we are using contract research laboratories that have got experience in carrying out long-term surveillance programs over many decades. That's the first point. You know, we're always using established kind of ISO standard methodologies, the reference methods for generating susceptibility by MICs and by disk zone diameters, so that things are, you know, all the data that we generate is cross-referenceable to other programs as well, and we make sure that we're testing consistent panels of antibiotics as well, so we have really good reference standards that from year to year. Okay, I think, you know, this data is of critical importance to industry, and I think it's often people don't realize that actually this data is important for us, not only in understanding our own antibiotics and our own compounds and how our compounds might work against different pathogens and different resistance phenotypes, but also this data forms an important part of the regulatory package of monitoring that we have to submit to the regulatory agencies on a kind of, you know, year-by-year basis to show that we still retain activity, you know, potent activity of our compounds against kind of contemporary pathogens that are circulating. So it's really critical that we can rely on that data, because it's really informing the activity of our drugs.
Thank you, Chris. Great to hear the value drivers for your company. So much appreciated. Next, I'm going to turn to Bruce Altavogt from Pfizer. And so, Bruce, in the last two panels, we heard about the researchers' use of the well-known Pfizer Atlas data to combat AMR. Why don't you tell us about what your hope going forward is about researchers' use of the Atlas data, and how can Vidley help you?
Yeah, thank you very much, Nina. You know, our commitment that we've had with Atlas for over 15 years of making our data available through the Atlas website, through web apps or mobile apps and so forth, is really around transparency and data for action. We heard very nicely in the last panel with Dr. Shetty talk about how it's critical that this data, that resistance rates, can inform policy and can inform practice. I think that's what we have been committed to at Pfizer for our 15 years of doing this. That's why we committed to providing our data to the ODI project as well. It's very important that we can harness the science and harness the scientific community. We don't know it all, right? We need to ensure that the scientific community can have access to this data to do the science that they wish to do. And come up with those ideas and investigate the data in manners that we wouldn't otherwise do. And I think that's critical, but it must be to inform practice and inform policy. I think those are the two critical elements that we'd like to see going forward. That's
so very interesting to hear about both the use for your own antibiotic stewardship and management, but also to leverage data for action, which in fact is the title of our conference, for policy. So thank you for emphasizing that, Bruce. And Greg Frank from Merck. We heard Dr. Cantone's use of Merck data to combat AMR. And what is your hope for the future use of Merck data, and how can we help you going forward?
Great, thanks, Nina, for the question. You know, I think you'll hear some similar, I think, thoughts as my colleague Bruce. You know, again, with our SMART program over the last 19 years, I think having this data not be used only for an academic exercise is a real key priority. And the one thing I will say is, just recently, late last year, this year, Merck has taken some steps through a new website to make that data more accessible. And I think that dovetails nicely with the Vidley mission of finding ways to make this data more visible. And because I think to Bruce's point, we want to make sure this is getting in the hands of researchers. But to the point of, I think, our aspirations of what we can use this data for, two things come to mind. And the first is this resistance trends data actually plays a critical role for identifying where we need to be taking the research and development prioritization of new medicines. These trends in resistance help us identify or make reasonable predictions of sort of where the ball is moving in terms of resistance urgent threats, if you will, in the future. So it plays a critical role in helping us marshal our own R&D resources. I think the other point, and really to echo Bruce's point, we really want this data to be used to drive action. You know, we don't want this to be only for a solely academic sort of discussion. Not that that's not very important, it very much is, but we want this to be driving policy change. We want this to be driving stewardship activities. We're really making sure that it's actually having an impact on AMR through all the areas that we think it could. And so to double back to your second question, which I've already touched on, we really do think the Vivli platform will help us increase that visibility and accessibility for this data, so it can be best leveraged for all of those items that I just mentioned. So with that, I'll pass it back to you, Nina. Thank you.
So thank you for sharing the 3 pillars: shaping R&D direction, policy change, and stewardship. So it can't be said enough. Thank you for that. Adam, I know you as a thought leader in the diagnostic industry. So would you describe for us the role of data in a diagnostics and medical tech company like BD? And tell us what you're excited about going forward.
Sure, Nina, and thank you for the compliment. Hardly something I do personally. I think it's really the team that at BD that's working in this space that helps me understand it quite a bit. Just very briefly, BD's in a little bit of a different position than some of my colleagues here from pharma. We don't generate surveillance data directly, at least not in the way that some of my pharmaceutical friends do. The way that we see data, or the way that data comes through BD, is actually through mechanisms that require hospitals, as well as outpatient settings, to generate information that they use for clinical purposes within a hospital setting, for example, and then report that information to national or regional bodies. So in the US, the NHSN, the National Health and Safety Network, requires hospitals to report information around infection rates, resistance rates, and other metrics. Because that work is difficult, it's challenging, it takes quite a bit of manpower to do manually, companies like BD developed software that helps automate reporting of resistance information. And so that data passes through software companies or software systems, one of which BD has. Now, the way that we've approached this is the system that we built, or that the founders of the company that made its way into BD built, is that we transformed that data and made it standardized across multiple settings of care, outpatient as well as inpatient. That data resides in the cloud and allows us to leverage it for research. So it's hospital data that's reported to the CDC, but a company like ours is doing some research with that work. And so we are sharing it where we can with the CDC, with IHME and ODI in support of their global burden of AMR work. Now, there's a lot that I think can be done. And so we're very excited about the initiative from Vivli, because public data really can transform the way that we think about resistance. Not only is it going to inform, are we making progress, as Dame Sally mentioned earlier, but it can change the way that medications are prescribed locally. And so I'll put into a chat in just a little bit a website that a pharmaceutical company put out. They're leveraging some of the information that we're able to compile, look at resistance rates at a local setting, right? So you can look at how does resistance in California, for example, differ from resistance in Mississippi or another place. That type of information, local, up to date, not 1, 2, or 3 years old, but really up to the month or up to the week, can hopefully change the way that we approach prescribing, both empiric as well as hopefully proactively. And then finally, just one last thought. We do think that having this data available to researchers can change the way that we think about quality improvements as well as policy guidelines. So Dr. Mendelsohn spoke earlier today about some of the work that he and his team are looking to try to do as they aggregate data from multiple sources. We're really excited about some of those opportunities and look forward to some of the ideas that academics who are hopefully going to be accessing this data from Vivli will come up with. Thank you.
Thanks, Adam. It's so good to see how BD is contributing to wider system strengthening through your donation of data to the CDC. And I understand that it was part of their annual threats report. Is that right?
Yeah, so
and what impact did it have?
Yeah, so in 2019, the CDC worked to update their antibiotic threats report, and what they wanted to take a look at is how did things change over time. And one of the things that you can do if you've got data that is standardized and longitudinally normalized over time is you can look at comparisons and trends. And so what they were able to do with BD data, but with other data sources as well, is to take a look at how have we made progress between the first threats report that was published in 2019. And what they're hoping to do, what the CDC is hoping to do, is get to publishing those threat reports on a much more frequent basis. I think it was 2 to 3 years between the first and the second threats report. Their goal is to try to get to publishing this information multiple times a year. They can only do that if information is much more easily accessible and more standardized in a way that allows comparisons across multiple settings of care.
Terrific. That's so helpful. I'm going to finally now return to Didem Torum-Kuni, and apologies if I didn't pronounce your last name correctly, Didem. But you were one of the original thought leaders in AMR surveillance data sharing. So if you could wrap up for us on what you see as the benefits of the platform, that would be tremendous. Thank you.
Thank you so much, Nina. First of all, thanks for inviting me. As a person who took part heavily in the preparation phase 1 of this project, I feel really so excited about being all together here. So, we know all together now, antimicrobial resistance is increasing in the world. So if you want to tackle antimicrobial resistance, it requires a multidisciplinary action. So it is the role of doctors, patients, pharmacists, governments, pharmaceutical companies, and academic researchers. So we are on the same boat all together. And we know there is a lack of good local antibiotic surveillance data in the world. And as it has been mentioned by so many speakers, we, pharmaceutical companies, have been generating local data for a long time. For example, within GSK, we started with the Alexander project 29 years ago, and today we are continuing with SOAR. So for 29 years of data is sitting somewhere in our web platforms. So once we generate data in pharmaceutical companies, we heard the way how we share data could be different from pharma company to company. Some of us, we have our own web platforms to share our data, and most of us, in general, we are publishing this data on a peer-reviewed journal as a manuscript. So first of all, this data is a good quality of data. During the phase 1 of this study, Wellcome Trust employed 2 independent consultants like Professor Barry Cookson and Dr. Liam Shaw. They did a fantastic job. They asked Shionogi, GSK, Pfizer, Merck, J&J to send their data study protocols and everything to them. And independently they checked and they said, this is a really good quality of data. So if the quality is good, why shouldn't we share it? So having Wellcome Trust and Vivli web platform will allow all of us to meet on one platform. It's like a one-stop shop for everyone, easy access to data. And once we share it openly, which means by providing the information about the specimen types, MIC values, and also, if possible, patient's background, this will allow so many researchers to do their own analysis. And also we should remember we are in the era of two different antibiotic breakpoints. You know, there are two institutions in the world, CLSI and UCAST. They are setting up antibiotic breakpoints and also AST, antibiotic susceptibility testing methodology. So for some antibiotics, sometimes breakpoints could be different. And in that case, if you don't have open MIC values and distributions, it's not really possible for anyone to do any analysis. Of course, as mentioned by some of my other colleagues, for trust and transparency purposes, it is important for pharmaceutical companies to share this data openly. So during the phase 1, we talk about short-term objectives and also long-term objectives. It's mentioned by Carla. Of course, this is my personal opinion, and it has to be discussed among all of us to get into agreement. But sharing data openly is the very first step. And moving forward, I really believe if we, all pharmaceutical companies, we share the study protocols, methodology, it would allow everyone to cross-check different methodologies, similarities, differences among all of us. Maybe moving forward, we can align some part of our protocols to make sure we are all big pharma, mid or small size pharma companies are generating really good quality of data. And also some of us are doing genotyping, some of us doing serotyping. It will be really good to align at some point in a long term on the objective of this open data sharing project. But thank you so much.
So Didem, you continue your reputation as a person who had the vision in the first place, and we look forward to continuing to work with you to make your recommendations come to reality if possible. So I'm going to ask the participants to put their questions in the Q&A. We do have a good question to start off with, and I'm going to read it to you now. Let me just, here we go. How can industry also contribute to a wider system strengthening? Some of you have addressed this already, but please expound. In the country's hospital and labs from where we've accessed isolates or data. And most importantly, is there an opportunity for private-public partnership? Who'd like to take that? Bruce, do you, I see you.
Yeah, Nina,
would you like to take that? And I can, yeah.
Absolutely, I'd be happy to start. I'm sure my colleagues have other ideas and examples. There are two examples that I'd like to pose that Pfizer is actively engaged in. The first is the SPIDER surveillance program, which is a partnership that we have with Wellcome Trust and 4 governments in Africa: Malawi, Ghana, Kenya, and Uganda. It is a direct equal partnership where Pfizer is providing subject matter expertise along with Wellcome to support the development of sustainable surveillance platforms within these countries, helping them in understanding how to process, evaluate the data, and then, as mentioned earlier, ensure that the data drives action within the countries and aligns to their national action plans. Importantly, the data is owned by the countries. The isolates are owned by the countries. We work very, very closely with the national surveillance programs already in place, the national reference labs, to really bolster their capabilities. I think it's a novel partnership between industry, nonprofit charities, and governments, and really has proven where and how all sectors can move forward and advance policy and care. Another example I'd like to provide is a grant program that Pfizer has to actually high-income countries. I think that we've had a lot of conversation this morning about where and how to support capacity in low-income countries, but we need to recognize that there are also barriers within many of the high-income countries. So we have grants in Europe that are providing support to hospitals on where and how they can leverage their data and support the analytics of their data in real time. Many of these facilities, have data coming in from microbiology labs, but the providers don't have access to that data in real-time capacity and don't understand where and how to evaluate it. So I think there's roles and responsibilities that industry can engage in supporting the providers in a compliant and also importantly an independent manner to support those access to that data as well.
Very helpful. Adam, sure, Chris, please go ahead.
I was just going to jump in.
No, you should.
I was looking for a little hand to put up. I just wanted to build on what Bruce said, really, particularly at the local level in the high income countries. Unfortunately, we don't in Shionogi have any programs in the lower middle income countries, but in the higher income countries, I think when new drugs come onto the market, we work very closely with the AST kind of development companies to develop the testing materials, and that is often a close relationship that takes a long time to actually to come to fruition. But it's important to realize that actually a lot of the time the new testing kits that come onto the market and become available, they need validation. They need to make sure that they're actually accurate in how they work and that they're giving high quality data. And so we've worked internally at Shionogi and continue to work very closely with local labs and actually country level reference labs to try and make available the new testing materials as they come available to those laboratories, and to do kind of validation studies with those labs to try and ensure that the data, that those kits are working properly, that the data they generate is consistent and reproducible, so that they can understand that data better themselves and how those testing kits work. Because obviously, for our longitudinal surveillance programs, we're using the kind of CLSI and UCAS reference methodologies to do our MIC testing and our DISP testing. But most hospital labs don't use those reference standards. They're reference standards because the reference laboratories use them, but they are using derivative methodology like the gradient strips or automated panels or other systems. And so it's really important, I think, that we work with these labs to make sure that those derivative testing methodologies are also generating high quality data.
Thank you, Chris. Adam and then Didem, you both have your hands up. I'm so glad we have so much interaction here. Adam?
I'll be brief. I think actually, Didem, you might have been first, but it'll be a very quick.
Oh, sorry.
Very quick point. So one of the, we certainly have challenges with regards to generating information around resistance, and some of the things that Bruce and Chris spoke about are certainly things that we need to do much more of. We need to also be able to, I'll call it, liberate this information a bit, move it across silos in a much easier way. Oftentimes the data, be it in a reference lab or even in a hospital microbiology lab, stays there, and especially in lower and middle income countries. So some of the work that Fleming Fund is doing to try to build capacity, not just for data generation, but for data sharing through laboratory information systems is really, really important. Sitting in a lab notebook, it's not doing much. And so doing that in a way that's standardized, or at least standardizable, is something that certainly from a BD perspective, that's something that we're working on quite a bit.
And Didem.
Thank you for the question. So we do this directly and indirectly in GSK. Directly, we are aware of that there is, lack of clinical microbiology capabilities in the countries where we are running our surveillance studies. We are running our surveillance in around 15 countries, mainly low-mid-income countries. So because of that reason, we are using centralized laboratories such as IHMA's laboratory. They are helping us together to make sure the data quality is there. But in the meantime, of course, we can't ignore it. We have responsibility to help. Therefore, we are running medical education meetings, purely medical, by involving and by working with globally known experts. Our hands are off, but there are speakers to educate clinical microbiologists on clinical microbiology techniques and HCPs on appropriate antibiotic prescription. And also indirectly, for example, I have been involved with GSK surveillance for 15 years, and I have 15 years academic experience. So company allows me to be advisor to different groups. For example, I am a technical advisor to the Fleming Fund, and I am an IFPMA representatives in Professor Evelina Taconelli's EpiNet by providing our expertise in surveillance in different countries in the world. Thank you.
Thank you, Didem. We have two questions, one for Rebecca and one is more of a comment. Rebecca, are you able to come online? I think, I certainly know the answer to this, but I think it's best for you to answer. Is VIVLI also looking at creating and sharing biorepositories of resistant bacteria to researchers?
That's an excellent question. In phase 1, that is not in scope for us, but that's an excellent thought for us as we look at our roadmap for phase 2 is to consider whether that might be in scope for us for a future development. But biorepositories of actual samples would not be in scope for us. I mean, the data from biorepositories could be, but we don't actually have physical freezers or refrigerators to keep specimens. So thank you for the question.
Okay. So we have just one more comment to share. One of our attendees has said that we must also make sure that documentation of systems is held somewhere secure over time. And this can be lost. Greg, I see your comment, and I'll call on you next. But so over time, this can be lost, organizations with memory issues and so forth. So this new data system should, in this person's view, be a repository for the methodological data. Just anybody care to respond to that?
I can maybe respond to this. I think what Professor Cookson is trying to say, that if I am not wrong, when for example, in pharmaceutical companies, in my company, as an example, the surveillance studies were running during the 29 years. Of course, one person is not leading this study. People may change from time to time, and the documentation in relation to all these surveillance studies, sometimes it's sitting in different departments, in different people's computers. So having one hub, this could be either each company's web platform if they have it, but if they don't have it, this VIVLI and Wellcome Trust web platform can be a hub to post all surveillance data moving forward. Even if people change in any company, then the data and documentation will be there and accessible.
And thank you. And back to the system strengthening question, Greg, would you like to shine a light on the work of MSD?
I don't want to take time because I know we're short. Just to highlight that, I think MSD,
we have 3 minutes.
Okay, fair enough. Well, MSD, I think, along with a number of other companies here, have initiatives that may not be been within the surveillance discussion that I think are aiming to strengthen systems. For example, I put in the chat 2 programs MSD has on sort of AMS program strengthening, which we think is really critical, especially in low and middle income countries of resource constrained settings. I think just want to really emphasize one point that Bruce and others have made around how, the VIVLI platform, by improving accessibility and awareness, especially to those local stakeholders that are engaging, I think helps provide that policy change that I think is needed for a whole host of things, including system strengthening. Because, one group of stakeholders cannot solve this, but I think, this data and how we use it in the conversation will drive, I think, sort of the vertical integration of multiple multilateral organizations, countries, and industry that can work together in an appropriate fashion to sort of build the infrastructure needed to ensure that antibiotics are not only accessible, but used appropriately and surveyed appropriately. So that's just the point I wanted to make. Thank you.
Thank you. In the 1 minute left we have, does anybody have anything that you'd like to share or state that you haven't gotten to from the industry perspective? I can tell you that I'm getting multiple requests from attendees to get a copy of the recording. So very good receptivity from our invitees. Okay, then. I'll just, okay, wonderful discussion and all the best for the Vivli Initiative partners. So that's another kudo. Thank you so much. I'm going to turn things back now to Rebecca.
Thank you so much to all our panelists, and really delighted to see the animated discussion. Thank you, Nina and all. So I will, so in our final session, I'll be talking to you about Vivli and the AMR Register, which will be launching in 2022. And it's really my pleasure to do so. Again, my name is Rebecca Lee. I'm the Executive Director of Vivli. I'll really be leading this effort along with a team. From our previous speakers, Dame Sally, Dr. Mendelsohn, and Dr. Canton, we've really heard quite a bit about the fact that even though we're in the midst of our current pandemic, we're facing our next silent pandemic. And Dame Sally emphasized that COVID-19 is quite honestly exacerbating this danger of AMR. Currently, AMR causes up to 700,000 deaths per year, and we could be facing globally up to 10 million deaths by 2050. So this is an opportunity for us together to address proactively AMR during our current COVID pandemic if we partner together. Together, we really have this opportunity to partner together. And this is why the G20 health ministers recently met earlier this month in Rome, and key initiatives really included not just ending COVID, but a recognition of how important it is to address AMR now and to each of the countries' sustainable development goals. What we're proposing today for this AMR register is not really an entire solution for AMR, but an important piece to potentially assisting us in addressing this next pandemic. So what we've heard today is that now there's no single platform for high quality industry data. This industry surveillance data would be accessible by researchers and public health officials globally. It could be used to detect trends for multi-drug resistance over time, as we've heard from the research panel, inform national and international policy, and also assist with antibiotic stewardship, as well as modeling of future resistance trends. So many of you were in the room in 2017 when Wellcome unveiled their proof of concept. This was conducted by ODI, the Open Data Institute, and on their platform. And key objectives for ODI's proof of concept included to demonstrate that high quality AMR data could indeed be shared. So that proof of concept included data sets that covered 93 countries and 85 antimicrobials. And conclusions from that pilot were that an independent institution should manage the AMR platform, and that would serve in the public interest. We're delighted that Wellcome has chosen us, Vivli, to build the AMR platform, and that was based on this successful proof of concept. Vivli, a data sharing platform and nonprofit, is really known for our clinical trials expertise, but we really hope to build on our data sharing approaches that has really proven very successful. And the objectives of this AMR platform is really to share AMR surveillance in the single platform, transition the initial ODI pilot data, and raise sustainable funding post-launch in 2022. We are currently the leading global data sharing platform in the space. We are currently sharing over 6,000 clinical trials. So that's IPD, which is individual participant level data. And that includes data from over 3 million participants and from over 120 countries. The AMR platform would share AMR surveillance data in a single platform and really try to bridge the silos between academic, private, and public information. We look to leverage our success in data sharing. We've been a nonprofit organization that really looks to convene various stakeholders successfully in the pharma space, academics, as well as nonprofit funders and foundations. Our mission is really in data sharing. So we harmonize language and agreements, and our mission is around lowering the barriers and promoting incentives around data sharing. We oversee the implementation of a data sharing platform built on Microsoft's Azure. So we serve the international community and have an open search, robust security, and modern tools and technologies. Currently, our industry partners include some of the largest pharmaceutical partners globally, so you can see who they are here, and as well as a number of biotech companies as well, who share their data on the Vivli platform. We've also partnered with members of academia, large foundations, as well as a number of NIH platforms who also have decided to partner with us and share their individual patient level data on Vivli. So all of this data can be shared and integrated together in a big data type way. We have since launched an AMR Register Scientific Advisory Board, as you can see here. This is chaired by Dr. Mark Mendelson. And this AMR Advisory Board advises us during the development of this platform, assists with outreach to key stakeholder groups, as well as advising us on the value proposition. How the register really works for researchers is, first of all, we see that researchers would come to search the register for data sets, make a request, then access the data, so either by download or be redirected to member sites to obtain access, analyze or utilize the data sets, and then disseminate and publish the results. This is how we envision the search to look, so researchers can search on any number of key terms of interest, such as antimicrobial, pathogen, sponsor, country, years of collection, sources. As someone conducts a search for studies, they would then obtain the studies that matches their criteria. The researcher would then integrate that data, analyze it, and then go on to publish their results. In closing, let me speak directly to funders who are present. We hope that you would consider investing in the AMR Register. We've heard from Tim Jinks today. Wellcome has generously been funding us through, and they will continue to do so through our launch. He's said in his opening remarks that they will be generously matching contributions, and this is an opportunity for you to contribute to our sustainability of the AMR surveillance platform. This would enable access to high quality industry data that would act as an early warning system to our next silent pandemic. For industry, we've heard from Dame Sally that those of you from the industry that may have valuable data, we ask that you would contribute and consider contributing your data. Many of you have committed to sharing as members of the AMR Industry Alliance. Some of you have signed the Davos Declaration. We also know Access to Medicines has the AMR benchmark that also has commitments, that also has scoring for AMR surveillance data as well. And we know many of you believe that this is an important scientific insight to make your data discoverable through a single unified platform. Lastly, we heard from the research and public officials panel about the value of surveillance data to public officials and researchers to identify outbreaks, predict trends, inform policy, and develop research resistance models and more. So I learned a great deal from that panel. So that how important this data would be if it was to be unlocked and made available to researchers. So we look forward to hearing from you once we launch in the middle of next year. So for my final wrap up, I invite Dr. Tim Jinks together to the podium with myself for our wrap up now. So Tim, if you could join me, please. Tim, thank you. If you could help me make final remarks, I just want to thank you all for coming today and for the robust discussion, for really helping us make this a wonderful day, and for all our panelists and presenters, for our moderators. I really enjoyed hearing from all of you, and I've learned a great deal as well from our discussion today. So thank you so much for our participants as well. So Tim, if you want to make any final remarks, I invite you.
Thank you very much, Rebecca. Thank you to you and the Vivily team for pulling this together, and certainly looking forward to further progress in the launch here. Of course, I want to echo your thanks to each of the speakers and panelists today. It's very important that they were able to share their insights. You know, from what we've heard today, it's very clear that there's an opportunity to bring forward real solutions to a significant problem. I hope that it is clear that this isn't simply a theoretical thing, but in fact, the reuse of industry-generated data is something that has practical application and can be done today. So this is not simply an area that is for interesting research, but goes far beyond that. The value is real, useful, and actionable, right? So this is about evidence for action. You heard that the concept of this has actually been in the works for literally now we're getting on decades. And what we are hoping to see that this is moving from the thought space through the doable space to the done space. And really, that's the next step that we would like to see here, that this is now something that is done that can play a role as a part of the big picture puzzle for how we provide relevant AMR surveillance to the world, to a number of stakeholders in different places who currently have insufficient data and information to inform their decisions. So with that, I'll simply close by thanking you all for your attention in this, and look forward to progress on this project in future.
Thank you, Tim, and thank you for all our participants. With that, we'll close the meeting and look forward to seeing you all soon. Thank you. Bye-bye.